Good morning, everyone, or good afternoon, depending on what time it is. All right, can I just have your attention? Hi, I'm Lisa. I'm the director here at the Senior Center. Thank you all for coming. I just have a couple of announcements. First of all, Irene had mentioned Ocean State Job Lot this week has 20% off everything in the store. It's their 41st anniversary, so in case people want to do some shopping this weekend. Also, I just wanted to let you know that the Uxbridge Library has a survey out right now that they're encouraging folks to fill out. That survey is available at the back table. It's also available online. So your input is very important, so please consider filling that survey out. Also, the Uxbridge Elderly Connection is sponsoring a Porchetta fundraising event for the Senior Center. That's taking place on October 6th at the VFW, and tickets are on sale right now, so you can get your tickets here at the Senior Center as well. We hope to see you at that event. Movie night is coming up on October 9th. Sign-up sheet is at the board. They are showing Smokey and the Bandit, so it should be a good time. We're getting a lot of good attendance at that. It's an evening event. I think it starts at 5:30. Is that correct? Yes, 5:30. So please feel free to sign up for that and come to that as well. And transportation is available for folks that need that. Okay, so at this time I want to introduce our speakers, Tracy DiStefano and Cheryl Betterton from the Uxbridge Orthopedic and Sports Therapy. They're located at 60 Quaker Highway, right near the Lydia Taft. And they're going to be talking to us about total joint replacement. So we welcome them. I also want to announce for anyone that is a veteran, local veterans, you no longer need to go to the Providence, Rhode Island for your physical therapy. The physical therapy is available at the Uxbridge Orthopedic and Sports Therapy located at 60 Quaker Highway in Uxbridge. So that's wonderful. You don't have to go all the way out to Providence for your therapy for veterans. So that's something good to know about. So thank you for letting us know that. All right, so we're going to do a moment of silence first, and then we'll have our speaker. So please, moment of silence. Okay, thank you. Enjoy your lunch.
My name is Cheryl Betterton. I'm a physical therapist at Uxbridge Ortho and Sports Therapy, and this is Tracy DiStefano.
DiStefano.
Thank you. And she's actually an OT she's director of inpatient rehab for Lydia Taft. So we're kind of tag teaming because we're talking today about total joint replacement. We're talking about total hips and total knees and kind of who's a candidate, what to expect, what things you can work on prior to surgery, what happens after surgery, and then once you're home again. So I'm going to start, and okay. So once again, we're going to talk about total knee replacement and total hip replacement. I brought models with me, just so you guys can see what it looks like. Okay, so this is the total hip joint. So this would be your hip socket. So it's called the ball and socket joint for a reason. So there's the socket, and there's the ball that would go into it. So that's what they actually replace. So they take out where you're bone on bone in there, and then they replace it with these metal, and there's some plastic lining in there as well. And then they actually, it's kind of graphic, but they kind of bang it into your good part of your bone, in your leg and into your pelvis. And then this is the knee joint. So this part here is this plastic lining, and then this other piece here, and that is the top part of your lower leg bone called your tibia. So that's one part that gets replaced, and then the other part, that's the bottom part of your long leg bone, the top part of your thigh here, that's your femur. They typically do not replace your kneecap. So usually people's kneecaps still are in good condition. If it needs to be replaced, they can replace the kneecap as well. So just to give you a little visual of what happens there. Okay, so who's a candidate? Typically older adults, although I have to say of recent past, I've been a PT for 26 years, so the last probably 5 to 10 years I see that they're doing it in a much younger population if it's needed. I recently had a 33-year-old total hip replacement. She was born with bad hips, and so she needed to have it done. So normally they do x-rays, so you might go to your primary care physician, or you might be going to an orthopedic doctor, and they'll take x-rays, and based on what your x-rays, if it's bone on bone, meaning there's no cushion left in those joints, and it's severe enough, then you might be a candidate for a joint replacement. The other candidates are someone who's just, their mobility is getting worse and worse because there's just wear and tear of those joints. Then my biggest thing is it shouldn't matter what age you are, it comes down to quality of life. So if you're having issues being able to do the basic things, but also things that you enjoy, then that's when you want to consider a joint replacement, because it really does give you kind of a new lease on life. And then the other candidates are those who have done all the conservative methods. They've seen the doctor, they've tried prescription meds, they've tried cortisone injections, they've tried gel injections, and then those get to the point where they don't work anymore and the person's just constantly in pain. Then they're also should be considered for a joint replacement as well. All right, so what to expect is typically if things are really bad, your primary care, if you haven't already seen an orthopedic doctor, will send you to an orthopedic doctor, and they're going to determine if you're a candidate. They may want you to try, if you haven't already tried physical therapy, they may want you to try some physical therapy, and if you haven't had any injections, they may try that route first. They're always going to try the most conservative routes first, and then if those fail, then that's when they'll start speaking to you about surgical options. So for physical therapy, not as much occupational therapy, sometimes the doctors will want their patients to come to physical therapy before surgery, and the goal for that really is for the physical therapist to educate and to teach the patient how to get the best range of motion, mobility, and maximize the strength and stabilization as much as possible before surgery, because there's research showing that those patients, once they have the joint replacement, have much easier rehab post-surgery and much better outcomes. So a lot of times we'll see people for like a short bout, usually 1 to 2 months before they're scheduled for surgery, and we'll try that. Okay, and then, so I told Lisa that I'm leaving this PowerPoint here because I didn't know how many to print off, but the next few slides are all like some basic exercises from a physical therapy standpoint of those muscle groups that we try to address if someone's coming into us for prehab, either for the hip or the knee, because basically when you have issues with your knee, you change how you walk, you change how you move, and therefore your hip muscles tend to get weak as well. So we actually spend a lot of time doing strengthening for the hip musculature. So what we'll do in prehab, obviously joints are bones, and so as we get older or there's lots of wear and tear in our bones, we lose those shock absorption and cushion in there, and so then you end up getting friction where the bones start approaching each other. So we want to minimize your impact. So you know, going for walks or walking on the treadmill is usually actually not the best thing at this point because it's causing more inflammation and irritation to the joints. So physical therapy, we still want you warming up before we're going to stretch you and have you moving. So our go-tos for warm-up tend to be the upright bike or the recumbent bike, depending on your balance and your mobility and whatnot. But that's a non-impact exercise just to get everything kind of warmed up and loosened up before stretching and exercise. And then what the physical therapist will do is then teach you some stretches, because a lot of times you get really tight, you don't weight shift appropriately when you're standing and when you're walking. So we just teach you some stretches, usually for your hamstrings, which is the back of your thigh that gets really tight, and your side hip muscles get really tight. So we do some stretching, and then we do some strengthening exercises, which are, even if it's the knees, we're going to focus more on the hip muscles. So the first exercise that I pretty much do with all my patients it's called bridging. So you're be lying in this position, and I tell people, obviously I don't want people getting down on the floor because it's hard to get up. So you can do this in your bed if your bed is firm enough, or you can do it on your couch if your couch is firm enough. So there are other options, but basically you're squeezing and lifting your bottom up and down, and really trying to work your butt muscles. Okay. And then the next exercise is, it's called a butterfly. So in our clinic, we tend to use what's called TheraBands. They're resistance bands. You can do it without too. It's just a matter of moving the legs, and some people don't have enough strength to even push against a band. But basically, you're keeping your feet together, and then you're pulling your knees apart, and then bringing them back in again. And then definitely, this is a big one. I'm sure if anyone's had physical therapy, we do this one, I feel like for almost every lower body diagnosis, is a straight leg raise. So basically that's working your top part here, and that muscle, your hip flexor, is responsible obviously for us walking and being able to stand up straight. So if that's weak and tight, then we're kind of in these bent over postures, and so we want to maximize that muscle. And then the other muscle that we work on is your side hip muscle. That muscle is responsible for holding us stable when we're standing and when we're walking, so we don't drop through our legs when we walk, which as we get older that happens a lot. So basically these are side leg lifts that we work on. And then the other sideline position one that we do is a clamshell. We tend to use the TheraBands once again in the clinic, but it's also laying on your side and just trying to pick up your top knee and lower your top knee to your other knee. And that's going to work the deep muscles in your hip that are responsible for rotating and being able to pivot through our hip. And then depending on your level and what you can do, definitely for someone who's having a total knee replacement, we do seated leg kicks. Typically, we're going to use ankle weights to give a little more resistance and try to build up the muscle. And then this one is, I typically in the clinic will hold the band, but if someone's at home doing a home program, this is for a hamstring curl. It's pulling the knee back and trying to work on this muscle here. So that's, once again, that's a very important muscle if you're going to have a total knee replacement. Your quadricep, which is your top thigh, in the front of your thigh, and your hamstring, which is the back of your thigh, are really important muscles for if you're going to be having a total knee replacement. And then we can get a little more challenging, a little more dynamic. We call it the band walk. It's sidestepping with a resistance band, going down the gym. We kind of sidestep, and that works those hip muscles and balance and stability. It works on a lot of things at once. And then another exercise we do is, especially for knee patients, we do step up. So we have you step up on the affected leg and then step back down again and do repetition, and that's going to work your quadricep muscle. All right, and then definitely for the knee again, the step down. So we'll have the person trying to keep the affected leg on the stair and then drop down and come back up again, and that's going to also work those knee muscles. And then we also do side step-ups as well, which is not something we typically do on a daily basis, but it does work. It's a good way of isolating certain hip muscles for strengthening. All right, and then I'm going to pass off to Tracy so she can talk a little bit about the lovely, fun equipment that OT gets to teach patients.
Okay, just let me know if I talk too fast or if you can't hear me, and I can always repeat myself. But part of what occupational therapy does is we work with people that have had joint replacements and try to help them be as independent as possible. So sometimes you need a little help with that, and sometimes you have to use some equipment. So I'm going to show you some of them. Going down the list here, we have there's different kinds, but this right here is a reacher. Anybody have these at home? Right. A lot of people get these, and they're all over. There's infomercials on them. There's all different kinds. There's ones with suction cups on the tips of them. But if we're going to use this to get dressed, then you want the one without the suction cups. You want one a little similar to this. Most of them that you would get if you come to a facility like Lydia Taft, you would get one that's gray, just silver, and on the end here, it's a little bit longer. It's not as rounded as this one. But a lot of people use these. If I said to somebody, you can only have one piece of equipment, 95% of my patients will say that they want this. We also can have a long-handled sponge. I don't have any of them here, and some people actually take them and therapy can heat it up and mold it so that it will shape a little bit different so it will fit around someone's back. But when we'll get into it a little bit more into the presentation, but a lot of times when you have your joint replacement, sometimes you come back with restrictions or precautions. One of them, it prevents you from bending a certain way. So in order to get washed and dressed without these things, you would always have to have somebody with you. So the next thing I can go over is a sock aid. This is what a sock aid, this is what we call a flexible sock aid, but there's more than one. So how many people have these at home? And see, now you'll notice that some of these go on, there won't be as many. But these now they're sold at Walmart, they're sold pretty much anywhere. But this allows you to put your socks on without having to bend down. So you basically can hold it between your knees like this. You slide the sock over the end, and then you take the two straps, one in each hand, and drop it down on the floor. So it will look a little like this. Drops down on the floor like that. And then you just pull the straps and you kind of wiggle it a little bit, and the sock will come off of the end of this and it will be on your foot. And I make it sound like it's really easy. It takes practice. I have plenty of people that try it and they need to, with repetition you get it. It's like when you learn to ride a bike, you didn't do it the very first try usually. So some of this equipment is just more practicing so that you can get used to it and kind of get the kinks out. Also, elastic shoelaces. Elastic shoelaces are really good and handy to have when you have either your knee or your hip done, because it's going to allow you to do put your shoe on without having to bend over to tie them. Some of these other things, a commode. A commode, there's several different kinds of them as well. There's some that go right over your toilet, just to make your toilet just a little bit higher, and that again matches some of those precautions because you can't bend your hip a certain way. You can't bend more than 90 degrees. So if your toilet height is not high enough, then you won't be able to use it without something on it to make it higher. The other benefit of the commodes are that as you get older, getting up and down can be a little bit harder. Having the toilet height be just a little bit higher, especially if it has arms on it, it's going to make your life easier. Some of the commodes can be freestanding, so they are used without the toilet. It just has a bucket underneath it. I always like those for people if you're sick and not feeling well and you can't get to and from the bathroom, it really helps. There's also tub seats and tub benches. One of the big things I always recommend, if somebody has a tub seat, I always recommend them to use one that has a back to it. Just for safety, that's more of just a preference, just because it kind of helps you remember not to lean too far back. And then they have tub benches. The benches, they're pretty handy because 2 feet are outside of the tub and 2 feet are in the tub. So that allows you to sit down and lift your leg over the tub instead of having to stand and step into the tub, which can be hard for people when they get their joint replaced and their balance is still off. So another thing, I just brought a couple other pieces here. There's the long-handled shoehorn. So they look very similar to a regular shoehorn, they're just a little bit longer. So and again, pretty much you can get all different kinds of them. You know, there's not just one type of shoehorn, just one type of sock aid. So sometimes we practice with different ones because people will have an easier time with the plastic one versus the metal one. So we try that out. Another piece that is I do have patients that like this. This is considered a dressing stick. So when you get your hip replaced, a lot of times you can get what's called a hip kit. Inside that kit typically is going to be the dressing stick, a shoehorn, I think the reacher's in there, the reacher, a sock aid, and the elastic shoelaces. So it's one kit, it has everything in there.
One-stop shop.
That's right. Now the dressing sticks, some people love them. They're a little bit, to me they're a little bit harder to use, but I had this one person that had rheumatoid arthritis, and this woman could do things with a dressing stick that I was so impressed. She could put her bra on with it. She was pretty impressive. So after you go and get the procedures done, if you're getting a total knee replacement, typically you're going to come back and there's not going to be a lot of restrictions on what you can do. So you are going to want to start physical therapy, occupational therapy as soon as you can. Whether you do that at home or you do that in like a skilled nursing center like Lydia Taft, typically the benefit of doing something like that is that you're going to get more therapy when you go to a facility. I was speaking to someone earlier and they were talking about how quickly it impacts your recovery. So when you go to, and you have your knee replaced, if you go to a skilled nursing center, typically you're going to get up to 7 days, depending on what your needs are, 5, 6, 7 days of physical therapy a week, and the same with occupational therapy. When people finish with inpatient, often they'll go home. When they go home, sometimes we recommend that they have home care therapy for a couple weeks because it's going to allow them to transition. You know, going from a place where everybody was doing things for them to going home to be by themselves and now have to be responsible for all these things. So I always tell people, you know, when I meet with them, the benefit of going home is you're using your own things. It's real life. This is what you do. After you do that for a week or two and you're starting to do better, the therapist at home, they're going to also say, okay, you know, you've graduated, you don't need us anymore. That's when I always recommend that they go to outpatient, like in Uxbridge here, because they have more bells and whistles there. They're going to have more of the equipment that you can use and really just strengthen up your legs. We'll go over that a little bit more. Inside, after you have your knee done, one of the things that physical therapy can do, they can instruct you on how to stand up using an assistive device, walking using an assistive device. They'll also, another big thing with physical therapy is working on managing stairs. Almost everybody has stairs that they have to encounter in their life, because you might not have stairs at your home, but at your daughter's home there is, or your son's home, or maybe over a friend's house. So we always like to try to do the stairs, because then it just prepares you for real life. Occupational therapy, we kind of went over the adaptive equipment there, but some of the other stuff that we talk about is we work on how to transfer on and off the toilet safely. We work on how to transfer in and out of the tub safely. We do work on getting you to be able to be as independent as possible and as safe as possible. One of the things that Cheryl mentioned earlier about, should you have your knee replaced or your hip replaced, you kind of go back and forth. I agree 100% that one of the most important things is your quality of life. So we really try to incorporate that into the occupational therapy. I've even so far as had, being a manager, having the physical therapist work with a patient walking their dog. And I had people say to me, why are you doing that? I said, because if you ask them what they want to do, their goal is to get stronger, to go home, to be with their dog. So if I know that they're going to have to walk their dog every day, but now they have a walker and they didn't before, then we need to make sure that it's going to be safe. So sometimes we have to be creative, but we really try to look at the whole person and modify their program to accomplish their goals. So as I mentioned earlier, once you finish with the inpatient therapy, then typically you would go home. The therapist will come to your house and do an evaluation, and based on their finding, they will recommend therapy. Typically it might be 2 to 3 times a week, and it does vary a little bit. Then once you get done with that, then you go to the outpatient. That's when they're going to really spruce everything up and do the fine-tuning. I'm going to let Cheryl go over a little bit more some of the therapy and the focus of outpatient therapy after you've finished with home therapy.
Yeah, so really the goal when outpatient, it's typically physical therapy, typically outpatient, occupational therapy has kind of done their job, taught you how to use all the adaptive equipment to be able to function and manage at home with your daily tasks. But really, especially after a knee replacement, you need still to maximize your range of motion, and you need to maximize your strengthening so that you can eventually walk and move around without an assisted device. It's typically a goal for most people because their pain was so horrible in their knee prior to the surgery. They either walked, gibbed horribly, or they used a cane, or they had to use a walker prior. So our goal is to have you as moving as independently as possible, and I like to say least restrictive assisted device. So we're going to try to get you down to the minimal assisted device or nothing, and that's really our goal. Okay, so going on to hip replacement, because total knees, there's really, like I said, we said no restrictions. So what we mean is there's no precautions. It's to your tolerance, which it hurts. I'm not going to lie to you guys. As a PT, I've been called the physical torturer before, and unfortunately, my role is to maximize range of motion in a new knee, which we like to talk about knees as they're a hinge. So you think about a new hinge, a squeaky door that needs some WD-40. A new knee is pretty similar. So sometimes you gotta force the range of motion a little bit. I always get my patients to try to move as fast as possible on their own, and then I help as needed, because the more that you're doing yourself, the better outcome there is. So that's total knee. Total hip replacement, different story. So total hip replacement, so as I mentioned earlier when I showed you the model, it's a ball and socket joint. So there's a lot more different ranges of motion that happen at the hip. You know, you have front to back, you have out to the side, you have rotation. So there's precautions because the doctor, the surgeon has to cut into a good part of your muscle in your leg to get in there, get out the bad stuff and put in the new stuff. So they don't want, because they have to cut into the muscle, you're weak. And there's a new joint in there. So they want to protect the integrity of the new joint. So they don't want you doing certain motions because that can compromise the new hip that's put in there. And it's temporary. It's until you get stronger where your muscles can hold and stabilize a lot better in there. So initially after surgery, especially the doctors around here, the Boston doctors tend to do a more minimally invasive procedures. The doctors out this way still do kind of what I call the old school method. They go in, it's called the posterior approach. They tend to go in through the back of your hip. And so they don't want you bending your trunk more than 90 degrees, and they don't want you lifting your knee above your hip, because just that motion that is extreme for that tissue that's trying to heal in there. The other thing is they don't want you crossing the operated surgical leg across midline, because once again, that's another move that with that fresh healing tissue can compromise the joint integrity. And I'm trying to think. Yeah, some have weight-bearing restrictions depending on what the surgeon needs to do in there, because sometimes there's other stuff, more stuff they got to do when they're in there. So sometimes they want you to really, really protect the joint, and so they limit the amount of weight you can put through that leg. So you'll have to be on an assisted device for sure to pick up the slack. But typically I see weight-bearing as tolerated. Do you? No, you don't. All right, you want to speak to that?
So a lot of times inpatient, we're going to get the people right after they had the surgery, a few days after. A lot of patients come to us with weight-bearing restrictions, and it's described in different ways, but it's usually a percentage. I've had people that come in and the doctor has told them they can't put any weight on that foot or that leg. I've had people come in and the doctor said you can just put toe touch. So all that allows you to do is put that toe down, just almost to help you balance, but not really. Because if I had you, I don't want you to, but if I had you all stand up and try to just put that one foot down, it's a lot harder than it sounds. And then we have people that come in that are partial weight bearing. So that's like a 50-50. So that means they have to split the weight on each side by using their arms and their other leg. And then there's weight bearing is tolerated. So inpatient, when we get somebody after a hip replacement, because we actually, more often than not, people, when they get their hips done, they need to come to a facility like us because there is a big change. They were able to do A, B, and C beforehand, but now after the surgery, because of pain and because of these precautions, they require more help than they can get at home. So they come to a place like Lydia Taft, and we do, in there we have occupational therapy, physical therapy, depending on what someone's needs are. We do have speech as well. But we have the physical therapy will work with people and help them, get in and out of bed, help them walk, and not just, it's not just walking, it's also the quality of your gait, because as Cheryl mentioned before, when your body is in pain, your body's like a machine, it's like a robot. When it's in pain, it's smart enough that it's going to compensate on its own. So that's one of the hardest things, is that you have somebody that might have knee pain, but their hip and their other parts of their body are going to start to compensate for it, because the brain is telling them you still have to get this job done. And so how are you going to do it? The other pieces, they kick in and they take over. So when you get your knee replaced, you sometimes have to relearn how to walk. When you get your hip replaced, it happens a lot. Sometimes people, when they're learning how to walk again, they turn their foot in. We want to make sure that they keep their foot straight, because all of those nitpicky things we're doing is for a reason, because we want to make sure that the hip is healing in the right position. Occupational therapy, when you go to a skilled nursing center, one of the things that we do, we focus a lot on being able to get yourself washed and dressed. All of those precautions that Cheryl just mentioned, if I can't bend and I can't lift my leg up like this, how am I gonna put my shirt on? My pants on. How am I gonna do that? I can't unless I have someone else do it for me or I use a piece of this equipment, okay? Some of the stuff you can cheat and you can get around, but lower body from your waist down, you really can't. It's hard to do. So some of the other things that we work on in occupational therapy is we're going to help you build up strength in your arms so that you can hold on to that walker if that's what you need. But also, we need to build up your arms to compensate for your legs just for while it's getting stronger, while you're working on getting your legs stronger. The other thing that we do is we work with people. Some people come in and when they go home, they're going to be responsible for cooking. And they're going to be responsible for some of the housekeeping, things like that. We're going to take that in consideration and we're going to have you practice, cooking again. I always tell people, I always laugh and I say, I'm not telling you how to cook. You don't want me to tell you how to cook. I'm going to show you the safe way to do it. Because you need to hold the walker in a certain place. You can't, if I'm only partial weight bearing, that means 50%, how am I going to carry that plate of food to the table? Think about it. A lot of you got up and got your own food and brought it back over. How much harder is it when you have something else in your hand, like a walker? Okay? You can't hold a walker and be safe and carry anything. So we have to show you it's tricks, ways that you can still do what you need to do, but do it safely. And then once, we talked about this already, but once you go home, a lot of times we recommend the home therapy. And again, it's just to get the transition from inpatient to home be as smooth as possible. That's when the therapists in the home, the benefit that they have is, like I said, it's real life for you. It's getting in and out of your bed, in and out of your tub, on and off your toilet, cooking and moving around in your own kitchen. We can simulate it as much as, or as best as we can, but reality is there's always little pieces that we don't realize. Different flooring, different lighting, all of those play a role in it. So having therapy come to your house, it allows you to be safer and allows that transition to be a little smoother. Then once you are discharged from the home therapy, that's when Cheryl comes into the picture and she can help focus on strengthening and using the equipment there.
Sorry. So normally, the hips tend to, like Tracy said, you guys, if you have a hip replacement, you tend to have to go or need to go to a nursing facility because you get, with the precautions, you need more assistance, learn how to use all that stuff. Then the homebound therapy, typically with the hip replacements versus the knee replacements in the home, they're in there usually a little bit longer, maybe up to a month, versus I feel like total knees, usually 2 to 3 weeks, and then they're ready unless it's their driving leg and they live alone, because that's another issue. You'll be considered homebound if you live alone and you can't drive too. You're still considered homebound and eligible for home services. And the one way to get back to driving is if it's not your surgical leg, so if it's your left leg that you had the surgery but your right leg is non-surgical and you're not taking pain medications and you can walk without an assisted device, that's kind of the criteria of letting you get back to driving again. So certainly once you can drive or you can have a family member drive you, you definitely want to get into outpatient as soon as is reasonably warranted. Normally for outpatient therapy, we normally see people joint replacement 2 to 3 times a week. And once again, it's all about trying to wean you, if you're on an assisted device, to get you down to the least restrictive assisted device or no device. Strengthening And then just making sure, I call it the fine tuning part of your rehab. It's kind of the end of the spectrum. So normally by the time you're discharged from outpatient therapy, you're back to kind of doing the activities or things that you enjoy doing or want to be doing, and you've regained your independence, which is the whole purpose for going through this, because it is a rehab process. Like I feel like when I first got out of school and was working with joint replacement patients, doctors didn't really discuss the spectrum of care related to it, and so patients kind of thought, oh, I'm getting a new joint, so after that I'll be fine, I'll be good to go. The rehab process is very, very, very important, the therapy part of it. I find those patients that come to me months after joint replacement that haven't had the therapy or as intensive therapy when they should have, they struggle. They're a lot weaker, they're not as independent, they still have compensations, which that's the whole reason for going through this, is to get back your independence and quality of life and not compensate and not be in pain. So that's really our goal. And then for outpatient, when you are discharged, we expect that, I tell all my joint replacement patients, I don't expect you to do 15 reps of certain exercises for the rest of your life. I mean, really, my goal is to get you doing exercises and doing a home program, and then once you're back doing the activities you enjoy doing, and hopefully there's some physical activity in there, not just sitting, then you don't need to keep doing the home exercise program, because you're back. The reason why you had the surgery was quality of life, to do the things you enjoy doing. So I know no one likes to do 15 reps of exercise. People come in, they're like, oh, I'm here today. I'm like, okay. At some point you're not going to be coming here. So, just like we all have to kind of muddle through, but then, at the end, I more often than not, patients are like, you've helped me so much, and, they go back to work, or they go back to golfing, or whatever their activity is that they enjoy doing. And that's why, joint replacement, it's such an amazing procedure. It always amazes me how long some people wait to decide to have a joint replacement, and they're like, I should have done this years ago. So, all right. Any questions?
What causes it?
What causes you?
Usually arthritis. I have a younger, I think I mentioned at the beginning, I had a woman who is 33. She was born with, it's called congenital hip dysplasia, so the way her hips were placed when she was born, she was breech. So she was in braces when she was a baby and all of that, and so her hips never developed well. So she's a young case, but typically it's wear and tear, it's arthritis that happens in there, and then it becomes bone on bone. So all of our joints when we're younger are nice and cushioned, and then unfortunately, as we age, we lose the cushion.
How early will it happen to them?
What? I'm sorry?
How young are the people that first start?
I've been seeing younger and younger, because I feel like people, especially Americans, we work a lot, and I see it a lot. I see a lot of carpenters. I have a guy who's a wood floor layer right now, a lot of construction people, because they're hard on their joints for so many years. And so by the time they're in their, I've seen late 40s, 50s, there's nothing left. The joint it's bone on bone at that point. So, and they can barely walk, and they're trying to still work. So they're great candidates, because they get a new joint, and they can, a lot of people can't afford to retire or go out on disability, and this gives them, many, many more years of quality of life. So, yeah.
Any other questions?
No. So if you need a joint replacement and want prehab, I definitely do a lot of it up at Uxbridge Ortho and Sports. We're on the same campus as Lydia Taft, and the Senior Center actually can provide transportation for therapy appointments if you need it, if you don't have people to give you transportation. So same with post-surgery, once you're home and you need to get to your therapy as well. So wanted to let you know that. Anything else?
No, thank you very much for having us. Hopefully we're able to answer some